Hello, everyone, and welcome. My name is Carrie Ann Viens, and I serve as the Associate Director of Graduate Admissions here at Bay Path University, and I'm so glad you're joining us this evening. Before we begin, I'd like to let you know that this session is being recorded, so you'll be able to revisit the material or share it with colleagues afterward. Today, Dr. Katie Everson will help us explore how occupational therapists use trauma-informed and sensory-based practices to support children and youth impacted by adversity. We'll look at strategies that promote regulation, safety, connection, and resilience across school, clinical, and community settings. By the end of the session, you'll leave with practical tools to create safe, supportive, and healing environments that help children thrive. So let's get started. And that's me. Hello, everyone. Thank you for joining us again. My name is Carrie Ann Viens, and I'm the Associate Director of Graduate Admissions here at Bay Path. And joining us is Dr. Rebecca Kellum. She's the Assistant Professor of Pediatrics and former public school pediatric occupational therapist. And this is your speaker this evening. So again, tonight's hot topic is on regulation as an occupation, evidence-informed strategies for supporting children with trauma, and we are honored to have Dr. Katie Everson as our guest speaker. Dr. Everson is an alum of Bay Path's OTD program and serves as faculty at both the University of Charleston and Baylor University. Her work focuses on trauma-informed care, sensory-based practice, and supporting vulnerable populations. Throughout the presentation, please feel free to submit your questions via the chat. We will also have a Q&A at the end. And now please join me in welcoming Dr. Katie Everson.
Hi, everyone. Thank you for joining. I can't see you, but thank you for being here. I love being an alumni of Bay Path. They offer such great opportunities, and I'm excited to share just some of my favorite information about being an OT today. Before transitioning into academia, I practiced in outpatient pediatrics as well as a behavioral health unit for adults, and then in the emergency room for the pediatric population. So some of this information is some practical interventions, some of the updated research, and kind of the why behind some of what we do, and then some of the behaviors that we see. And again, if at any time there's questions or something you want to add even, feel free to put it in the chat. I think I can see that as well. Okay. Oh, I hit the wrong button. Okay, so let's sort of talk about why this matters. And why I sort of came up with the title for this one as regulation is an occupation. More and more, we're seeing children, we're seeing adults that have significant trauma, but also just the everyday life or everyday trauma, some of the new, or some of just existing or being a human is really causing some nervous system disruption. So all of this work or all of this research or all of these strategies really matter in any setting that you're in, pediatrics through adults. My research or my focus just tends to happen to be in the pediatric population. And then kind of on the importance of just like, what is regulation? I feel like regulation and trauma are such hot topic words or really impactful words, and we're gonna break it down kind of what that means, and then what does that mean from the OT lens, right? So how do we promote safety? How do we support connection? And how do we support regulation? I do like to have you try some of the interventions, like we'll pause and try like a movement break or some deep breathing, and always know that I can't see you, but at any time, you never have to do or never have to try what I'm talking about. Everything is always optional. Okay, so here are just a couple learning objectives that I came up with by the end of this presentation, right? I really want to define what it means to be trauma-informed care, but as an OT, what does that mean from our lens? How sensory processing supports trauma recovery? What are the links between sensory processing and trauma? not only identify, but hopefully practice a few sensory-based interventions. What that may look like across different settings. So the school setting, community-based, even in the home. And then what it means to build resilience and talk about a strengths-based approach towards the end. Okay, so let's really define trauma first. So trauma to me is the word that I choose. You can really substitute this for stress, anxiety, dysregulation, but I like the word trauma because it holds more weight and it holds more meaning. So every single person in the world has experienced trauma. Birth is a trauma. However, the way that our body will process trauma is that we store it as, or that birth trauma, excuse me, is a more of a positive experience. When we are born and we sort of enter the world out of the womb, right? We take that first breath, and then when they connect us with our caregiver, the sound of the first cry or the first breath, and then like the primal like connection, smell, attunement to your mother helps that response sort of settle in your nervous system, and you don't perceive it as a negative traumatic event. It's also really important to not only talk about these major life traumas that you'll see on the slide, but as I mentioned earlier, trauma or stress to the nervous system is an everyday occurrence. So oftentimes that quick alarm when you're in deep sleep, right, that's dysregulation to your nervous system. Being late for work, or forgetting to do your homework, or not eating breakfast, skipping a meal, right? Those are all kind of events to our nervous system that can cause us to have a difficult day, or have different behaviors, or really struggle to just get through class while you're waiting for lunch, things like that. Some of the more acute or chronic or complex, right? I never want to discount any of the major T's, the bigger traumas, leave lasting impacts, right? We're seeing that more and more on children of all ages. So from preschool to high school, all the way through adulthood, the impacts of all of the traumas are much more prevalent, or we're talking about them more, or we're noticing them more. We're noticing how important occupation is. So whatever is meaningful to that person or that child is really what's making the lasting change to their nervous system. It's also really important to know or to recognize that trauma is a very body-based experience. I think a lot of times people are like, oh, you've experienced trauma, you should go talk to someone. Well, new research is saying that that is actually more re-traumatizing. It's not about talking about your trauma anymore. It's really moving your body through specific movement patterns that help your body and your brain process the experience. And so trauma is really defined as what happened to you, or no, I'm sorry, not what happened to you, but how you experienced an event that happened to you. So two people could have a very similar day, a very similar upbringing, but their brain and their body will process it much differently than each other. So it's not about putting anyone into a box or putting it into a label like you've had trauma. It's more of how did you experience an event that happened to you. And so what I love about being an OT is that all we do, or not all we do, a lot of what we do is that brain-body connection. So anytime I work in, or I'm specifically targeting, say, trauma or stress or anxiety, I want to get you out of your brain and into your body and focus on helping you store, process, figure out how we take these swirling tornadoes of events, experiences, or emotions and make you resilient. New research is also saying that yes, it's a body-based experience, and where we store trauma is in our core and in our pelvic floor. And if we don't move our body, and if we don't target our pelvic floor or that movement component, we still end up almost re-traumatizing or not finishing the process of understanding our own trauma. So it's no longer sitting and rehashing or re-talking about what it is that you went through. It's taking yourself through specific movement patterns that help your brain sort of come to terms with the event that you went through. And I hope that makes sense. We'll kind of work through that as we keep going on. Okay, so then we have this term, the trauma-informed OT, or trauma-informed care in OT, or what does it mean to be trauma-informed? So they have a lot of great frameworks. They have a lot of great research or a lot of great methods, but what does that really mean as an OT? So I mentioned before, right? It's really body-based. It's all about tuning into your core, tuning into your body, really figuring out what your body is trying to tell you, and then you'll have a much easier time of changing your brain. But SAMHSA does describe the principles as safety, trustworthiness, peer support, collaboration, empowerment, being culturally responsive. Then you have those 6 R's, right? To realize, recognize, respond, resist, repair, and build resilience. And again, this is just another lens to look through, another framework that can guide us. But oftentimes it's easier to sort of take a client, take yourself, sort of how you feel in certain areas. How do you know that you feel safe? Or what does trust and transparency feel like to you? And how do you then share that with others? When I'm in session, so for example, some of the guiding principles of R is that we realize, right, trauma affects the brain, the body, and the nervous system. We realize that behaviors are adaptive responses, not always intentional defiance. And we realize that regulation changes or challenges can be sensory, emotional, or even social, right? So we realize there's more than just saying no or someone refusing to do a task that we would like them to do. It's taking a pause and realizing, okay, maybe they don't have a sense of safety. Maybe I'm missing collaboration. Maybe I'm moving too fast and our sensory systems aren't syncing up to get what we need to be done. When we become trauma informed, right, we have a deeper sense of understanding what fight, flight, freeze, or fawn patterns are and how we see them in ourselves and in others. We understand more about like sensory seeking or sensory shutdown, interoceptive awareness, right, or difficulty with transitions, right? So we're able to sort of decipher what dysregulation looks like in a client we're familiar with, or with a child that we know, or, okay, I know you're having a really hard time getting to the end of the day, getting on the bus and going home. How can we implement some regulation tools or use regulation as an occupation based on what I know or I recognize in that specific child? We'll also talk more about this too, but being predictable, using predictable routines and strategies and structures, responding in a similar pattern the best that we can really helps that sense of safety, or we know the way that we respond in specific situations matters, right? The way we talk to parents, the way we talk to kids, we have to create our own sense of safety that works for both of us. And as always, right, we want to avoid re-traumatization. So we're not looking for forced participation, power struggles, that unpredictable touch, kind of like a consequence to their survival behaviors. It's always about choice, empowerment, and co-regulation as well. And that's how we sort of bridge the gap in being like, okay, this is a great framework, but I know as an OT, I'm really body-based, or I know my specific client has a really hard time transitioning between each class. So my role as the OT isn't really an individual session. It's more of recommending tools and techniques to prevent that dysregulation from occurring before the transition occurs. Okay, and we'll talk more. This will come back to again later on. Wrong one. Okay, and so let's then define regulation. Okay, so regulation in itself, right, is that we want our child to be regulated. We want our child to stay seated, to pay attention, to focus on what they need to be doing. Regulation is different for everyone. Every person has a different level of where they feel regulated or where they feel safe. It's an autonomic nervous system connection. So it's really something that is driven in the back of the brain that our frontal lobe is trying to control. So oftentimes we're teaching these skills about do the zones of regulation, or take a deep breath, or what can you do to get yourself in a regulated state? And oftentimes that just doesn't work. It's the choices that, or the setup, the routine, the action steps that children take to keep their own nervous system regulated. It's how we can see a child seeking out movement, or needing a snack, or seeking out some form of connection because they can't get their own body in a regulated state. Regulation is foundational. We know that you can't learn, you can't take in new information, you can't socially engage unless you're in a regulated state for learning. And the second tricky part is that we oftentimes want to teach self-regulation first, but a child cannot self-regulate unless they've experienced co-regulation. And that is their ability to really see themselves in another person. Typically that happens at birth. Their caregiver provides that early on co-regulation, or their ability to connect. They can understand that they exist as their own person, but then they are regulated by someone their nervous system syncs up to or connects with. If you've ever seen like the still face experiment, a mother plays with their baby, the baby laughs, it goes like a back and forth, it's very rhythmic. And then the mother turns into a still face, and the baby becomes like immediately dysregulated, is crying, is overwhelmed. So that happens to all of us throughout the day. We look for validation, we look for feedback, we look for connection. Connection is a basic human necessity, and oftentimes we're missing a key component of that to create our ability to regulate on our own. And then the OT's role, right, is always going to be that sense of, okay, I need now for you to understand what it takes to build a routine for your own regulation or for your own nervous system, or how can I get you into a space, or how can I recognize, going back up right to those 4 R's, how can I recognize that your body is ready for learning, and how do you recognize your body is ready for learning? And oftentimes a lot of this comes from nonverbal communication, it comes from play, it comes from exploring different tools and trying new things in the moment, that all of a sudden you can take a very back brain sensory approach and move it to that frontal lobe, sort of storing your coping skills. Okay. I always forget to click over that. Okay, so now let's take a few minutes and play a little bit in the sensory world. And if we think about sensory processing, right, we can define that as your brain's ability to process a stimuli in the environment and almost code it into a message, and then give you a behavior output. So much easier said than done, as I think most of us are OTs in the webinar here, or have some familiarity with sensory processing. We all have sensory processing differences. So we will wake up and have a sensory need, and we go to bed with vastly different sensory needs. They fluctuate throughout the day. It's almost as, right, we call them sensory diets. We call them sensory cups. We need to fill our sensory cup. We need to check in with what each sense needs, all of that good stuff. But when it comes to children, adults who've experienced chronic trauma, right, all of these are wired differently. Each sense plays a different role, and it's our job, or our role, our process, to support and understanding our own sensory processing and how it supports the nervous system of the child or of the client we're working with. And then we help them learn their own preferences and differences. So to me, it's not really a sensory processing disorder. It's more of a sensory processing need or a sensory processing in just sensory processing in general. And I say this, I have a daughter, she's almost 6, and she has pretty, I would say, moderate to severe sensory preferences. So I speak as a mother living the research in real time and someone who has spent a lot of time in the textbook or reading about it or seeing what other people are doing as well. So I have a kind of a two-fold approach to this as we work our way through. But let's break down sort of the 5 regular senses, or the 5 like original senses, and then our 4 regulating senses. And I'm going to do this for time's sake a little bit brief, but if you have any questions or like where did that come from, you can always let me know. So we know that sight is responsible for 85% of sensory processing. And so a very simple way to view this is I will have participants, you place your thumbs, you can't really see me, right on the back of your head, the top of your neck. You're just looking for like a little pressure kind of right on the back of your head. And then I have you move your eyes side to side, and you just feel a slight movement in the back of your head. And so the way I like to demonstrate this is your eyes have to take in all of the stimuli first, and then it has to get processed all the way through your brain, all the way to the back. And then whatever that stimuli activated is like a tidal wave that goes from the back of your brain, and almost like a flood will shut down parts of your brain that it deems in threat or not necessary for survival. Things that could be bright lights, the color red, a familiar face, right? It's going to activate something in the brain and the body, and it puts them into survival mode throughout the day. And it's very autonomic. It's the back of the brain and the brainstem. There's no language. You can't reason with it. It happens on its own, and it's going to take over any form of frontal lobe reasoning that we think our clients may or may not have. Smell. So smell is really directly associated with procedural memory, and we can use this in 2 ways. So there can be a smell in the environment that was present during a traumatic event, and it will activate the trauma in the body. And so, right, you could bring out maybe a different snack in the classroom, a perfume or lotion someone is wearing. There's a new teacher in the room. Something activates a sense of smell that activates a memory, and now that child's body is reliving the traumatic event. And they could really dissociate. They could become high energy. It could go whichever way their body needs to sort of survive the situation. However, on the other side, if we have a positive memory, we can use these to our advantage. So if we know there's a certain smell that immediately takes that midbrain, back brain, and heightens it in a positive way, we can use those. Sometimes people like peppermint or eucalyptus or lavender. Fresh baked cookies, right? It's kind of the Christmas season, so all the Christmas candles are out. Sometimes we can use those as almost pocket tools or to our advantage to say, okay, I'm not going to reason with you, but I'm going to incorporate a form of smell sort of in the background and see if I can activate some part of your brain that has taken over and just calm it down a little bit, where then we can sort of offer more co-regulation. We also have sound, right? So we always know like loud sounds will create that startle response, or loud sounds will initiate the Moro reflex, or loud sounds or certain songs or certain frequencies or certain programs, right, are going to offer different tools and tricks for regulation. We also know that vibration and music will open more parts of the brain than anything else. So if we ask, right, adults or children to tell us a nursery rhyme, like Twinkle, Twinkle, Little Star, it's easy to pick up the rhythm and the timing of the song. Or if a song comes on the radio from like 5-10 years ago, we can, and it was one of our favorites, we can sing every word. But then if I ask you, say, to list, right, 3 favorite songs, or to tell me what your favorite song is, it just takes your brain a little more of a hesitant or a quick trick to sort of flip the learning back on, or the ability to answer a question. We also know that sound, right, is going to be directly related to that moral reflex that I briefly mentioned. And so if we know trauma is stored in the body, and it's stored in your pelvic floor and in your core, and we know the moral reflex is flexion, extension, and breath, a lot of my body-based work is always going to be that movement pattern. It's always going to target the core. It's going to target that trauma reflex, because even though our clients or our children look like they're going through the day, they're functioning, walking upright, our brain is subconsciously stuck in the fetal curl. It will go back into that protective moro reflex subconsciously, and we have to take our body again through those specific movement patterns and open it back up and say the threat isn't real, or the threat is not going to harm you right now. It's okay to work our way through. So flexion, extension, and breath is going to be like a key component to a lot of the body-based or the sensory interventions we'll do later on too. Okay, and then vestibular is really important, right? So oftentimes people with trauma will, it's almost like they're just so disconnected from their brain and their body. They constantly have a state of dizziness, or just really inability to connect to their own body or the world around them. They're so focused on living in that survival state that oftentimes we'll see a lot of vestibular dysfunction, or fear of moving their body in different planes. They are really kind of, even though again, we look like we're functioning upright, but our nervous system and our body underneath is really stuck in that, or that tension. The same for proprioception. So I always tell everybody, if you don't know where to start or what to do, or when in doubt, always choose that deep pressure. So deep pressure is going to be the quickest way to regulate an anxious or an overwhelmed nervous system. It's just going to remind the brain to check in with the body and say, okay, we're still here, we're still functioning, we're still able to sort of tune back in. So when we're stuck in a heightened survival state, you could even see this as like accident prone. So if you're ever like stressed or thinking about all the things you need to do, and then all of a sudden you like trip over your foot, or it catches on something, or you end up like smacking your hand on the table and you're like, wow. It's almost like your brain trying to signal to reconnect to that. Like our brain will reconnect from our arms, our legs. It'll start distal and move its way proximal because it doesn't view it as a need for survival. So we have to sort of reconnect and tune back in and offer that form of deep pressure to rebuild that brain and body connection. A lot of the sort of movement activities that I like to show or do in person sometimes are kind of the deep pressure. So rolling over a ball, squishing each other, sock wrestling, even adults all the way up to our kids to adults too. It offers just the deep pressure, and it offers that flexion, extension, and breath and connection. Okay, let me move my way through. So then there's also interoception. So interoception is almost now at the forefront sort of mental health research. So it's talking about how your internal organs, right, are going to regulate your body, and that really plays a huge role. Hunger and thirst, bathroom, being able to sit upright in a chair, and it really is focused on like gut health. So all of the bacteria, all of the food, all of the essentials that are kind of swirling around in our gut our pelvic floor will transition right up to the brain. So they say interoception can really dictate mood, can really sort of focus on or change the way that we think, not only think about in the moment, but how we think about ourselves. It's that key, that connection, that pathway to real or true brain-body connection. Okay, and then we have our neuroception. So in your neuroception is great because it is frontal lobe and brainstem. So in your frontal lobe are these mirror neurons, and they will determine your sense of safety in relation to people and to objects. So they will look at someone, and right away they will determine if that person is safe or unsafe. And children who have a lot of fighting in the home, domestic violence, or chaos, right? The sense gets hardwired differently. So they tend to seek out situations that others may presume as unsafe become safe to them, or kind of safe relationships. They don't feel comfortable, or they have a hard time connecting in sort of a relationship that isn't as chaotic. Right? And so it's our job to really rewire this sense with specific boundaries, really breaking down the social sense of safety. And because those mirror neurons are stored in the frontal lobe, this sense can be really hard to work on, because we know during times of stress, during times of like trauma activated, our frontal lobe actually turns off. So we store our coping skills, all the coping skills that we teach our kids or that we've been taught, right? They're going to be right up in that frontal lobe. Personality, judgment, and humor, sort of like mindfulness, active learning. And that, yes, that doesn't only just live in the frontal lobe, but oftentimes we see that as a frontal lobe higher level thinking. We have no access to that when our sense of safety is putting us in danger mode. All we really have is what our back brain or the brain stem will offer, which is breath and movement, where we can calm our safety signal just enough that we can then turn back on the frontal lobe and say, okay, I see you're in distress. Let's try X, Y, and Z and help you. Right? So there's going to be a lot of breath and a lot of movement. If you are a person or you know someone who's ever experienced a panic attack, right? That oftentimes is, right? That really like short of breath, I can't breathe, I'm going to die. And then somebody comes up to you and they say, well, how can I help you? And you were like, I have no idea. If you try to help me, I'm going to die. And if you don't help me, I'm going to die, right? So we have to sort of take the verbal communication and the reasoning out of it. It's all about co-regulation in the moment. So breath patterns, tone of voice, our ability to really connect to someone else and say, you are safe, we're offering you this sense of safety, just enough where then we can say, okay, let's do a coping skill that we've talked about, or I see that you're now sort of in the red zone, let's try this strategy over here, and help their brain and body set up that neural pathway that works for them. And speaking of that, I also forgot to mention, right, if you think about the initiation of life, of conception of human nature, it's sensory processing. So the first thing that forms is that neural tube, right, in the womb, and that's your initiation of sensory processing. So whatever happens in the womb does matter. They say now your like foundation of social emotional processing is 0 to 2 months. So whatever happened during that time frame doesn't ever mean, right, the brain doesn't consistently or constantly change. It's almost just the pathway of how you are going to perceive the world or how your sensory systems are going to function. Okay. And so now we almost have, there's this new predictive brain process theory. So not only is it that 0 to 2 months, epigenetics are now a huge role. So they say we now carry the trauma or the life experiences of our maternal grandmother. It gets passed down 2 generations, and it plays a role in that predictive brain process. So what that means is our makeup, our genetic code, who we are as a human, right, has these predictive features where we are going to almost like automatically respond to sensory input. And when I mean this sensory input, I mean like any stimuli from the environment, right? So they say sensory processing disorder is non-harmful stimuli are now harmful to our nervous system. Okay, so there's a prediction pretty much already laid out in your body, and it leads to that unbalanced interoception. So like inside something's not right, that chemical dump occurs. So those neurotransmitters are firing, that cortisol, the dopamine, the stress, all of the good and the bad are going to sort of dump in. And then we have our pattern of fight, flight, or freeze, or fawn, depending on where we go. And then it causes an energy drain, which leads to a further unbalanced interoception, and the cycle continues. And it further sort of teaches our nervous system that, yes, that sensory input or that stimuli or that event is going to constantly dysregulate me. So how we can think about this, right? So I talked a little bit about my daughter. So right now she, clothes are a really big deal. So every day I have to stretch the neck of her shirt until she can hear it rip. She only wears 1 pair of pants. I have it in 3 colors, and everything has to be stretched and loose, certain shoes only, right? So I'll think about her epigenetics. I was pretty much the same way, very similar in my sensory preferences and needs, but parenting yourself or parenting someone with similar sensory input is actually really hard to sort of offer the right co-regulation, because it's like both of our nervous systems can't really sync up because we're both overwhelmed by similar stimuli. And so instead of the change in the statistical prediction to the green side, right, where I know this, like proprioception or the deep pressure or a hug from your mom or laughter with a good friend, right, that offers your body to feel good in the moment, releasing those good chemical dumps, which continues to build social engagement, which then replenishes your energy and tells your brain to predict that this sensory input, right, is going to be a good one or is going to work. So it's our role as OTs, right, to understand sort of this process. And now how do I take something that the brain is predicting is going to be a negative sensory input or a negative experience, and how do I slowly get it to either be kind of in the middle or go towards the green? This new research too, it's come the Community Resilience Initiative. So I learned about this at the last AOTA. They offered a trauma-informed educator, and if you want more kind of information on this side of it, that's just a really great resource to go and check out. Okay, so then what does that mean for like interventions, or what does that mean for the realm of an OT? So now we need to sort of take what we know, and then what we know as like people as OTs, and sort of the information that we just talked about, right? So trauma is going to shift our sensory thresholds or our ability to process sensory input, right? Then we need to break down fight, flight, freeze, fawn patterns. Can we recognize them in ourselves and then recognize them in others? We can rely heavily on our frameworks, right? I'm a big PEO girl. My coworker in the psych unit was a MOHO guy, and it was so funny to kind of see our brains work differently but get to the same result. and how they can also be combined, right? So one of the parts of this too is going to be talking about environments and how important the role of the environment plays to sort of help with that sensory stimuli and things like that. Okay, so let's break down the arousal continuum and then the window of tolerance. So this kind of circles back to that, those R frameworks. So being able to recognize our child, our clients, ourselves, our own window of tolerance. And what that looks like is sometimes you can even think of like a red cup. And people with a lot of trauma or a lot of chronic dysregulation, the cup is already full. And then one simple stimuli from the environment comes in and they've gone from 0 to 100. They are bouncing off the walls. They are easily upset, quickly to be angered, quickly to shut down. It's difficult for them to stay in that window of tolerance, or another thing we can call as their safe regulation. So I always talk about we're building that window of tolerance. We're getting you out of your fight, flight, freeze, fawn patterns and bringing you back into the green zone, back into your regulation, your regulated state, or your green zone. It's also important to really recognize that the window of tolerance is going to be different for everybody. So my window of tolerance, I like a lot of stimuli from the environment, or I like a lot of feedback from peers, relationships, the environment, all of that. Whereas somebody else may be so overwhelmed by how much stimuli I need on a regular basis, right? Sometimes when I would be running groups in the psych center, right? So groups could be 5 people, it could be 15, it could be 30, right? It could be whoever kind of shows up that day. My energy or my attunement will sort of set up the group tone, right? You always know if you're running a group in the school or you're picking up kids, however you sort of set the boundary. Is it going to be a high energy group? Is it going to be a really focused group, right? That all matters because we sort of set the tone for what the window of tolerance for those around us are going to be. Okay, so then we need to break this down too, just to make that a little more clear. So where we want to be in our social sense of safety, right, is going to be this parasympathetic nervous system activation. It's very ventral vagal. Everything is on. We have oxytocin. We have like you're present. You can feel what your body is doing. And this is where we have like the ability to connect, the ability to learn, mindfulness, being in the present moment, right? This is where we want to be. Alert is essential, right? So everybody should be going through fight or flight at some point. You need to be able to recognize that danger in your environment, whether it's a danger or not. Our brain and our body should still alert us to that. So fight and flight, right? It's not, you never should not go into fight or flight, right? Our body has to go into it, but then we should be able to come back down, right? Back into social engagement when we've realized we're in a sense of safety. Well, a lot of us don't deactivate. So a lot of us keep going higher up into fight or flight, right? So that's kind of, if we have chronic anxiety or if we have chronic pain, a lot of digestive issues, trouble sleeping, changes in appetite, right? All of these fight or flight responses. If you have panic attacks, if we see people get really irritated or frustrated really quickly, right? And then after a prolonged period of heightened fight or flight, we can go into freeze or fawn. Fawn is part of that now too. And our body literally will shut down. So this is where we see sort of like the suicidality, depression, feeling really hopeless. Oftentimes our kids can't really put words to that. And like our digestion shuts off. You'll see kids with a lot of bowel and bladder dysfunction, appetite changes, right? They're showing all of these symptoms. That is a clear nervous system dysregulation. And we're trying to work on some of these higher level skills. Because that's what we're told we need to do, or that's the role of our setting, right? But if we're trying to work with somebody who's stuck up in freeze, there's really no active learning. We can teach them these coping skills, or we can teach them these motor skills, but if their brain and their body aren't ready for it, there's going to be no sustained learning. There's no mastery of a skill. Their nervous system just isn't able to allow it to happen. So the only way to really pull clients out of freeze is going through fight or flight. So we work in small doses that offer that fight or flight reaction. So we call it feeling comfortable, feeling uncomfortable. You can call it distress tolerance, right? It's sort of working your way down. So you get short periods of this green zone, but yes, you will go back up, or we will see people get back stuck in freeze or have the same similar behaviors or patterns, right? Because it's just normal to work our way through. But after a while, we improve that window of tolerance and they say, okay, I can take on more, or I can make myself feel comfortable in things that are making me feel uncomfortable, right? It's just tolerating longer periods of discomfort to promote that actual regulation. I hope that made sense. Okay, so then what is this co-regulation or the regulation framework, right? So I mentioned before too, self-regulation doesn't work without co-regulation. So this is us offering that sense of predictability, or I know what your body needs. So I know that my daughter doesn't really need to be like rushed to get dressed in the morning. I have something that she views as safe clothing. I offer more deep pressure hugs each time, and I say, okay, we're gonna do two rips of the, 2 rips of each sleeve and 1 of the neck, right? So I'm telling her brain, right, okay, this is the routine, this is the mastery of safety, this is the predictability, so that when it comes to the clothing, right, she's not already in a sense of discomfort. Now, does that work every morning? No, sometimes we have our moments, right? But when I know that I can stick to it or offer that sort of co-regulation, it really does make a difference. Attunement, right, is very nonverbal. So my energy or the energy of the therapist, right, as I said before, sort of sets us up for success or dysregulation. Oftentimes in sessions, in different settings, maybe not the school, more of the outpatient clinic I was in, I would create dysregulation because I wanted to work through it and offer the connection to have their body reach regulation, right? To show the parent like, okay, we're gonna get all jacked up, we're gonna get our energy high, and then by the end, we're gonna have a tool that sort of brings us back down before I send the child home with you, right? To show them the difference, the changing of the nervous system states, and again, have them pinpoint what regulation looks like for them and their child. Because most of this work comes from the caregiver, right? So in different settings, it's really important that the caregiver is involved, because that's where the neuroception, the sense of safety, the co-regulation, right? All of that develops. And yes, you may never even meet some of the caregivers in a school setting. But if you think about it, they're with their teacher or their aide or whoever it may be. There should be one person, hopefully, in the school setting that kind of is their person. So we should be moving out of sort of everybody gets an individual session, right? We all know that the caseloads are way too high. Everybody needs OT, right? So it's more of a consultative role, or how can I set you, your caregiver, and your environment up for success that makes that intangible feeling of safety, of joy, of happiness into tangible objects. So this was a great study that just came out. It was more focused, I believe, on autism and ADHD, but it can still have similar patterns related to trauma, right? So we're talking about how different deep pressure or different rhythm and movement activities, trying different breathing techniques is going to be really impactful for, like, it works. They're just showing, this is like, there's studies, there's research now that is giving sort of support, I guess, to these specific interventions. For time's sake, let's just practice 1 or 2. I had a couple to share with you, but we'll just start here. So one of the techniques that I always offer is like a breathing for panic. So like I said before, right, panic sounds It's that heightened breath. It's really high up in your throat. And then I have clients move their breath to stress breath. So a lot of us really are living in chronic stress. And that sounds like this. I sort of pinpoint like right sort of at my sternum, like my diaphragm, like mid chest is easier to say. And it's going to sound like, so still really shallow, but not panic. And then where we want breath, right? I sort of hook my finger in my belly button and I really want to open my airway and then bear down into my pelvic floor. I want to move my breath all the way down. So it sounds like, sorry if that's loud on my microphone. I'll do one more, but I'll back up. Right, so research says too, the longer the exhale, the more opening of the vagus nerve or the more release of the trauma. So I teach clients to move their breath through each compartment. So what that sounds like is 3 breaths in panic here, 3 breaths in stress, and then 3 breaths in deep regulation or deeper breathing. Right, so I have them do that right when they wake up and right when they go to bed. So what was once a coping skill that's going to be stored in the frontal lobe, right? So we're always telling people, take a breath, go do breathing. It happens now automatically. I'm storing that in the back of my brain. And so when I go into panic, my brain and my body already have the habit, the role, the routine, the motor plan, the motoric movements where it knows to just do that on its own. And it will take you through breath and it will, again, calm that part of your brain just enough. Another one that I like to do is I have people cup their hands. So you place one on top of the other, and then you do the push and the pull. And so it's a quick, deep pressure of, or just quick, deep pressure, right? So you push in and then you pull out, and then you add breath. So it's another one. I know you can't see me, but it's going to be flexion, extension, and breath, right? So I'm taking that very primitive, that very early on motor pattern, and I'm starting it in a very safe way. So if people don't want to rough and tumble play or they don't like touch, right, they'll do it for themselves, and they're just going to start the brain pattern. They're going to start that neural pathway of that flexion, extension, breath. Okay. And then, so our role, right, is we go and we bring up different environments. So as I said before too, right, it's not about offering the tier 3 where we are doing all of the modeling or we're doing all of this work or we're offering and practicing sensory diets, right? It's sort of how can I step into some of these other ones where I'm either setting up a meaningful environment or offering different exposure to stimuli that's going to be regulating or dysregulating and then working our way through it. It's how can I support a larger need as just like one OT oftentimes. I know the caseloads are high, right? The need is high. And so it's how do we share this information or how do we teach about sort of syncing up teachers, caregivers to understand that behavior is communication or unpredictability is a sign or a need of predictability, right? So how do we teach these different tools and how do we translate that across settings? You will see sort of the community-based interventions, right? Research says it only takes one person. So one person that you feel safe with sets your nervous system up for success. But what if we had a community, right? What if we had a community of people who understood how to be trauma informed? Or how do we have our school, everybody's sort of doing the same principles or working together on a topic. My daughter is in elementary school, right, and the whole school just took on the zones of regulation. So it's not just coming from the OT or certain teachers, it's coming from the principal, it's coming from the assistant principal. They have it in every language. They have it as like a form of communication, right? How do we take these resiliency skills and put them into a community of support. And then it wouldn't be OT if it wasn't routines, right? So it takes 21 to 64 days to build a new habit. Within those 21 to 64 days, if you feel forced to do something, so if someone tells you, okay, you have to sit and meditate or sit and focus on your deep breathing, it will take over 400 consistent repetitions of that one activity across that month, that 2 months before that neural pathway even starts. However, if we do things out of play, out of autonomous choice, out of something that we know is meaningful to ourselves or our clients, it only takes 10 to 15 repetitions for that neural pathway to begin. Right? So we know, again, with that breathing technique, we're going to try it in the morning, we're going to try it at night. I know my client has a really hard time with transitions, or it's that time off the bus, that 4 to 7 hour when they're home with their mom, that they say that they're wonderful in school, but they come home and they are having a really hard time, right? Some of the behaviors or some of their communication is starting there, right? So it's about using what the body is already telling us and working that into our advantage. So the goal is always going to be resilience, and resilience comes with relapse. It comes with the trans-theoretical stages of change, right? Bad days still happen. Sensory stimuli disruptions still happen, but it's working to continue to build resilience. So it's no longer eliminating stress from our lives, but it's making us better to handle it, or our cup doesn't spill over when one stressor or event sort of activates our response, things like that. And then just to close out, sort of the key takeaways is that regulation really is an occupation. Oftentimes it's talked about as a skill we need to teach or we need to build, but if we view it as it's more than that, or it's just part of an everyday task. So as much as we need to shower, brush our teeth, use the restroom, right? We need to incorporate sensory and regulation so that we can be our best versions of ourselves. And it's children who've experienced trauma, you know, they're not broken. They're just doing the very best that they can with the nervous systems that they've adapted for survival. And so when we show up with empathy, predictability, sensory understanding, and regulation, then we can support their nervous system. And that's what OT is all about. Sorry that my dog is barking if you hear that. And that is all I have that I went through rather quickly. So here are some references, and then if anybody has any questions, I'm open to it.
Great, thank you, Dr. Everson. I will give folks a moment to type their questions into the questions box, and I'll go ahead and read them out to you.
Awesome, thank you.
Mm-hmm. Okay, sorry about that. My mouse froze for a second. Let's see. Let's see. How do you facilitate buy-in from teachers and staff?
I had a pretty good experience with that. I think teachers are really sort of, they have a lot on their plate and they have a lot to do, but they're also still looking for help. So there's a lot of kids that are really presenting with high needs, or are coming in with a lot of trauma, like right at kindergarten, and they're just open to any ways that they can help them. And so I will typically ask to, like, what can you realistically take on? Or let's start simple with some sensory ideas and try these out. and let me know how they work, right? So it's not like I'm not bombarding them with a full sensory diet that they have to or follow through. It's just simple, small suggestions. And then if they're open for more, sort of giving them the resources or the support that they need as well.
Great. And the next one I'm seeing is, sorry if this was already mentioned, but how can we help children who've been through trauma learn to calm their bodies and their emotions kind of themselves? Like, what tools can we possibly give them even at a younger age?
Yeah. So these are great whenever. And so like when in doubt, it's going to be movement, right? So oftentimes children are expected to sort of be calm or sit and pay attention, when in reality, the antidote to trauma is going to be connection and movement. So the more that we play, the more that we move our body in any way that feels comfortable to the child. Like I used to wrestle a lot with kids. I used to sort of throw them around like the yoga ball, just sort of anything that offers core movement and then connection with either you or their caregiver is typically the easiest way. If it's sort of like a younger infant, rhythmic rocking is huge. If you're working on like infant mental health, or I spend a lot of time also with children born exposed to substances. So sort of regulating their nervous system and recognizing it for them in the moment, and then teaching their caregivers how to adapt to that.
Great. The second one I'm seeing is, what are your top recommendations for movement within a school setting?
Yeah, okay, so that can be tricky, but it's almost like, what can you do, or how often can you get movement? Like, I'm not a huge fan of like the wiggle chairs or giving them the bands to kick. If that's all that they can have, anything is good. But I also like to say, like at a certain time each day, can they take a regulation walk? Or one of the teachers in a second grade classroom had like a yoga mat in the back, and there were yoga poses, and it was like at the same time every single day this client or the student had to go back and do certain poses and then, or movements, and then return to the desk. So it's about like prepping the body or catching the body before it goes into that dysregulation or the need for their body to ask for movement themselves. It's more like building that habit, the routines, the predictability that allows their nervous system to stay regulated.
Great, thank you. Well, those are all the questions that I'm seeing for now, but this was a lot of fantastic information. So if anyone thinks of anything as they're going, oh, never mind, I did see one come through, and it's got a couple parts, so hang on one sec. Are trauma-informed strategies similar to or overlapping with mindfulness activities? At first, I felt there were many similarities. However, after the CE session, it seems like they are pretty different, as trauma-informed sensory strategies focus on calming the body first, whereas mindfulness strategies focus on internal states.
Yeah, I definitely think there is some overlap and then definitely some differences, right? So from my knowledge of mindfulness, it's about tuning into the present. So it can be sort of taking your nervous system from where it has wandered to, or wherever your brain has wandered to, and like bringing it back into the moment. Whereas some of the trauma-informed sensory is, okay, let's stay there and let's offer either a little bit more chaos or a little bit less chaos, and let's just sort of see how the fluctuations go. Or maybe we need to bring your window of tolerance, we need to get to that heightened state, and we're going to stay in that area for a while and see how we can implement different strategies in there, right? So there definitely is some overlap, and there's definitely some benefits. Like I really can't see one without the other, and both play a major role.
Great. Okay, I'm just pausing for a second to see if anyone has anything else, because let's see. Okay, I'm not seeing anything, like I said, for now, but we do have Dr. Everson's contact information here as well, if you think of anything in the meantime. Let's see. And then so also just here at BayPath, we have for OT, we have 4 different programs. You can see the information here. We have our MOT full-time on-campus program, along with our Bridge program, and then an MOT part-time hybrid program and our post-professional OTD. This is our contact information. So if you have any questions regarding any of our OT programs, this is our contact information. And thank you, Dr. Everson, for sharing your expertise. And again, for any questions, please use the contact information provided. You will be receiving this recording tomorrow morning. But we appreciate you joining us tonight. The recording, the slides, and CEU emails will be shared soon. We'll now transition to a closed professional community session for an OSEP grant mentors and mentees. And please remember, this meeting uses a separate Zoom link. So look forward to seeing you at future events. And I hope everyone has a great evening.
Thank you.